Good evening, and thank you for attending AACP's webinar with Dr. Tony Bolamperti, presenting treatment of snoring with the 9.3 micron CO2 sleep. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. The webinar is approximately 45 minutes, followed by a 15-minute Q&A session. Please enter any questions you have in the Q&A box at the bottom of your Zoom screen, and we will address them at the end of the presentation. The AACP has no conflicts of interest. Registrants can expect to receive a recording of this presentation via email within 5 to 7 business days, and AACP members attending live will receive their CE certificate of attendance within 30 days of the webinar air date. I would also like to mention a couple of upcoming events for the AACP. Our next complimentary webinar will be June 14th with Dr. Stasha Gomanak, presenting 3 simple steps for healthier sleep. Also, for education, camaraderie, and the latest in craniofacial pain, be sure to visit aacfp.org and register for this year's annual symposium in San Antonio, Texas, August 11th through 12th. Our speaker tonight is Dr. Tony Bolamperti. Dr. Bolamperti graduated from Creighton University Dental School in 1995 and began practicing with his father. In 1997, he opened his own private practice, Optimal Health Dentistry, and rebranded his practice in 2016 to Omaha Laser Dentistry. In addition to his practice, he enjoys being a part-time faculty member at Creighton University's School of Dentistry. Dr. Bolamperti has over 20 years of laser dentistry experience, specializing in airway-centered dentistry, laser frenectomies from newborns to adults, gingival contouring, oral surgeries, bone grafts, dental implants, cosmetic and anesthetic-free dentistry. He is a convergent dental trainer and speaker and an ambassador for Dr. Zoggy's The Breathe Institute and the Breathe Baby Institute. And with that, we'll hand it over to Dr. Bolamperti.
Thank you, Shay, and thank you to the American Academy of Craniofacial Pain for having me provide you with this webinar on the non-surgical snoring solutions with the 9.3 micron CO2 laser. We'll start that. Shay already kind of gave you a brief introduction about myself. And, you know, the thing that I really have enjoyed in the past 20 years is just the educational courses that I have pursued, expanding my horizon and my clinical abilities with using laser technology to assist me in all these wonderful procedures that I normally wouldn't be without that laser. So it's been a joy. Getting into airway center dentistry has been incredible experience, and it seems like you can never learn enough because you just keep learning. And so, you know, with anything tonight, I would just encourage you to learn as much as you can about airway center dentistry. The American Academy of Craniofacial Pain is going to have an incredible symposium coming up in August, and I will expand this lecture a little bit further into detail. So I encourage all of you to attend that. It's going to be an awesome event in San Antonio in August, and I look forward to it. So with that, we'll start this presentation. Snoring is very prevalent, and you know, although studies show that 67% of the population snores, I would probably gather, especially from my own research in my own office, that it's higher than 67%. You know, with everything going on and you know, the pollution and seasonal allergies, all other kind of effects, I think that's a higher number than 67%. But it does impact both genders. It's never just one more gender dependent. However, I do find that most of the patients that I do treat are male than female, and I'm not sure if that's because the you know, the spouses kind of pinpoint their husbands or spouses saying that he's snoring, so that they have to show up at the office to get examined and do a comprehensive exam. But it does affect all genders, and it does impact relationships causing one to sleep in a different room because of the snoring impairing the other sleeping. And it is very common with patients who have obstructive sleep apnea. And so this is something that is very easily to diagnose and discuss within your practice. You know, sleep does have a huge impact on our overall health. And, you know, that has been studied and proven over time. And studies show that it does impact our overall health if we do get less than 7 hours of sleep. And keep in mind that if you get more than 7 hours, what is the quality of that sleep? You know, so, you know, a lot of patients, when I talk to them, they say that they sleep, they go to bed at an early time and they get a good 7-8 hours of sleep, but the quality of sleep, if they're not in that deep sleep, that REM sleep, it's not quality based. So if you don't get that restful sleep, it's going to affect your mood and concentration. It's going to affect stress. It's going to affect your immune system. A lot of patients, if you do start to pursue examining your own patients within your own office, you're going to find a lot of patients who aren't good sleepers have heart disease. They have COPD. A lot of them are diabetics. And you start looking at their oral cavity, you start to see the wear, the attrition, the breakdown, the tori, you know, just that disease manifesting itself intraorally. So chronic conditions do kind of coincide with a poor sleep quality. So be on the lookout for those kind of conditions within your office. And obviously you can see the difference in the amount of hours with sleep and how that impacts those conditions. So there's two different kinds of snoring. Most snores are palatal, and that comprises roughly 80%. The other 20% are nasal. And of that, the 20% could be they could be both a palatal and a nasal. So I have treated patients in the past who have, we've kind of concluded that they are a palatal snore, and we've treated them with the 9.3 micron, but they may be a little bit of nasal snoring where it's less epic or less loud. And so that 80% snoring of the palatal flutter is caused by that vibration of the uvula and the soft palate. Now with the nasal snoring, that can be influenced if you cannot breathe through your nose. So say you have patients who cannot breathe through their nose because maybe they have a deviated septum, nasal passages are collapsed or calcified, causing them to mouth breathe. But also tongue posture can also impact snoring. So the palatal flutter is our primary objective for treating patients with the 9.3 micron. It will not treat those patients with the 20% for nasal snoring. One way to differentiate between the two is if you can just have your patients try the breathe right strips. And a lot of times patients will have already tried that and will conclude that, hey, I'm still snoring with the breathe right strip. So again, majority of your patients will be a nasal a palatal flutter. So snoring versus obstructive sleep apnea. In normal breathing in health, we breathe through our nose, and the mouth does not have a filter system. So I always like to ask my patients, and it's kind of a hard question because they really don't pay attention to it, is, are you breathing through your mouth or your nose? A simple question to ask is, when you're driving your car, when you're at rest, are you breathing through your nose or are you breathing through your mouth? If we are breathing through our nose, our nasal passages, that is healthy breathing. That goes through the nasal passage to the turbinates, to the sinuses, down to the lungs, and you can exhale through the mouth or through the nose. In partial obstruction, we tend to breathe through the nose, but also the mouth. We have a very hypotonic soft palate. So you can see in that slide that the soft palate and the uvula is impinging on that passage, and that negative air pressure, say, is causing that vibration. Now, obstructive sleep apnea is total closure, and that's when we tend to stop breathing. That's the obstructive sleep apnea, and that's complete blockage with the uvula and the soft palate impinging on that space back there. So in treating with the 9.3 micron, we are not treating obstructive sleep apnea. We always have to make sure that we inform that to our patients and educate them that this is not a means of treating obstructive sleep apnea, but more so just treating the snoring. And if they're snoring, that means at least they're breathing, which is a good sign. So some different anatomical complications that can result in palatal snoring, which I already mentioned was nasal obstruction. A lot of patients in the last 5 to 6 years, I probably have referred more patients to the ENT than I have in my close to 30 years of practicing dentistry. And if they can't breathe through their nose, I have to get my patients to be able to breathe through their nose. I need them to nasal breathe. And so if they're obstructed, they are going to the ENT that I refer them to. Mouth breathing, that's another complication. If they're noted to mouth breathe more so, I want to know why. Why are they mouth breathing? Do they need to see a myologist so we can start other means of maybe getting them to nasal breathe? How's their tongue posture? Is it relaxed? Is there a tongue tie? Is there tethered tissue? Is there skeletal discrepancies? Are they so severe class 2 that they need to see a good orthodontist and possibly have orthodontic surgery? So, there's so many factors that can contribute to this snoring that we're trying to treat. So you want to make sure that you're able to diagnose and treat these properly so that you have success with this, because it is a multifactorial issue. Palatal snoring is. So a lot of things can cause these obstructions. There's other factors, environmental factors that contribute to that, which is your BMI. What is your weight? If I have a patient, I have had a multitude of patients who have come in and their diet, their BMI or their weight is excessive. I will always encourage them that diet and exercise is probably one of the factors that will influence that greatly. And so I encourage them to exercise and maybe have some weight loss in their plan for better results. Because if you do treat patients who are excessively overweight and do not have a good diet, your results are not going to be as well as if they did lose weight. Alcohol consumption will always lead to snoring. When I treat patients and they do their Snore Lab app, which I will talk about later, they may have a night where they had an epic night of snoring. And if you pursue that, they may say, oh, I was out with my friends, had a couple cocktails, a couple glasses of wine. You're going to snore with alcohol consumption. Everything nowadays is about energy drinks. The younger generation have a lot of energy drinks that keeps them up, that keep the cortisol levels up. So energy drinks, you want to refrain from that prior, at least a few hours before bedtime. Smoking, I don't need to say much about that. Eating prior to bed. Going to bed on a full stomach is not healthy. So we want to try to avoid eating excessively or eating dinner a couple hours before bed. And then the obvious light distractions in the room. Our forefathers back in the caveman days, when the sun came up, that told them it's time to go hunt. So anything that might distract proper sleeping in the bedroom, TVs or phones are huge distractions, need to be turned off. And then you get into a lot of the anatomical related components. You're checking your Bolamperti, you're checking the pharyngeal grading. Again, the upper airway distress, inability to breathe through the nose, the TOTs. Those are all components that you really have to pay attention to and understand how that impacts breathing. So how do you identify your patients who snore? Simple questionnaires is a great way. That's always a great way to kind of open the door to snoring and inquiring the patient. There's different questionnaires. I like the Stop Bang. You can try the Berlin questionnaire. You can try the Epworth. Those are all simple little single questions that they can answer fairly quick. I like to do a Bolamperti classifications. I will say that 99% of the snorers that I treat are Bolamperti 3 or 4. I have never treated a Bolamperti 1. I have treated probably just a couple Bolamperti 2. Those are easy cases. But Bolamperti 3 and 4 is the majority of the patients that I do see. Neck size. I used to always kind of check the neck size, measure and write that down. I don't do as much other than I just make a visual examination if they have a large neck. Obviously, if they're a little bit overweight, the neck size is going to be larger and that's going to impede in the airway. So again, diet and exercise. And then you have your BMI. I'm not a big fan of the BMI. I don't like to go by that because according to the BMI, we are all overweight. So I try not to base it strictly upon neck size and BMI for that reason. Keep in mind, if you suspect that a patient has sleep apnea, I always promote and encourage a sleep study to be done and to be read by a qualified medical specialist for OSA. So the stop bang is pretty simple. You've got the S for snoring. Do you snore loudly? And most people will check yes on that. Are you tired? Are you fatigued during the day? Have you stopped breathing? A lot of patients will say that their spouse or significant other has noted them stop breathing. That's a big red flag. High blood pressure. Are they being treated for that? Are they on a medication? Again, your BMI. What is your age? The neck circumference, and then the gender. One thing I don't like about the stop bang is for most males, if they're over 50, it's almost like you get three, you get one more on there, boom, you're already at an intermediate risk of having OSA. So don't use the stop bang just as a means of diagnosing OSA, just as a means to bringing up the conversation, maybe making the patient acknowledge certain things that can cause snoring, that can cause OSA, to get them more familiarized with that. So as dentists, ever since 2017, the ADA has really kind of allowed us to and encouraged us to screen patients part of our comprehensive dental examination for these sleep-related breathing disorders. And, again, simple questionnaires or simple just talking to the patient, asking them about their sleep behavior. And this also kind of continues that we have a referral-based program for our pediatric patients, especially if they do need to seek help. And obviously, we're encouraged to screen patients younger than we have in the past for developmental problems. I do treat a lot of babies in my office for tethered tissue. And so it's not uncommon that we do see infants at the age of 1, and then 2, and then 3, and then every 6 months thereafter, checking for tethered tissue, checking for nasal breathing, checking for palatal width. No longer are we doing palatal expansion when they're 10 or 11. We're trying to get that palatal expanded as early as possible, as 5 years of age is prime. And then continually updating your knowledge and training with, some great education, continuing education on sleep medicine, such as joining, the Academy of American Academy of Craniofacial Pain would be a great, educational tool to use in the future. So we have a big role in sleep-related breathing disorders. Now, treatment options for snoring. If you ever talk to your patients with all the social media, everybody has a smartphone. They've gone on there, they've had access to it. We've got chin straps, we've got different oral appliances, a lot of crazy things. Usually when patients come to my office, they've tried 2 or 3 different applications to help with their snoring. And at that point, they're still unsuccessful. But you may run into some of these, the snoring device, nasal devices. These tend to open up the nasal passages, thereby allowing them to breathe a little bit more fuller through the nasal passage. The problem with this is it only addresses the nasal snoring. So that does not address the palatal snoring. So if they're having high success with decreasing snoring, wearing a nasal snoring device, great, problem solved. If they don't have success with it, they're probably a palatal snorer. They can also have access. I've had a lot of patients who have ordered these anti-snoring appliances online where it's actually just moving that jaw forward protrusively, and they have some success with that. If they can wear it, if it's comfortable, they do have some success with it. So it has a higher efficacy, but it has to be worn. A lot of patients may start out their sleep with this. By the time they wake up, it's on the bedroom floor. The downside of that is it can cause some occlusal issues if you're not using it correctly, especially your OSA, mandibular oral appliances. I've seen a lot of patients with posterior open bites because they're not using their AM aligners correctly. It has a fairly good compliance, but it does have a lot of cons to it. So be very careful with these snoring appliances. And then least favorite of these, and I've had several patients undergo this before they got to me, was the uvulopalatal pharyngeoplasty. This is a procedure that I will probably definitely not recommend. Encouraged to try different applications or treatment recommendations before doing this, because it is a very painful procedure. If you ever have a patient, talk to them about how it went. They may say that for, not just a few days or a week, but probably a month or two, significant discomfort. And snoring does decrease, but it does come back. So I have had treated several patients who've had this procedure done with the 9.3 micron to alleviate snoring, because they still, even though their uvula is gone, which I'm not a big fan of, they still have a hypotonic soft palate, which is causing that flutter. So this is just a quick video showing the 9.3 micron. It's a 7mm spot size. There is a pattern that we pursue, or that you can kind of go through, so that you're hitting the soft palate, you're accessing the uvula. You're about 2 to 3 centimeters away from the target site. You need a nice dry working field. We do use Ceticaine topical spray to kind of numb that, because it does have a sting to it. And there's typically 2 bursts per site, and it's just a great way to to treat this. And it's very simple. It's non-invasive. It does turn the tissue red, and it usually takes 2 appointments depending upon the Bolamperti. Treatment time is less than 15 minutes. So I give myself, for that first appointment after the consultation, half an hour just to get the patient prepped, Ceticaine spray, explain the procedure again. Actual laser time is about 15 minutes. And during the procedure, minimal discomfort because of the Ceticaine spray. Post-operatively, minimal discomfort, kind of like they had a cup of hot coffee. I've never had one patient who was in so much pain or discomfort that they had to take an Advil. More so is just kind of that first evening where they feel like, yeah, I feel like I had a cup of hot coffee. And so it doesn't do, it's non-ablative. It is just working on the collagen. The laser energy is heating that collagen up to a certain degree, which is 60 degrees Celsius. And so that allows for the collagen to start to contract. So as you can see, it's a fairly simple application with the handpiece from the 9.3 micron. So how does it work? Well, our target tissue is in the lamina propria, the collagen. That's where the collagen-rich material is what we're going for. And the lamina propria is about 50 to 150 microns deep within that epithelium, down into the dermis. So we're not going beyond the lamina propria. We're not falling short. The 9.3 micron CO2 energy was designed to get to that lamina propria on contact. So that's why it's a very quick procedure. Once it gets to that, the collagen starts to contract instantaneously as it is broken down because of the heat application of it. And again, this is non-ablative therapy. So in comparison to the different wavelengths out in the market, you can see that the 9.3 micron gets to that absorption depth of the lamina propria in the soft palate. Your erbium energy is further on the about 2.94 microns, and it doesn't get to the lamina propria. So for the erbium, you have to go through several rounds or applications to fulfill getting that lamina propria to that level. And so that may take up to 40 minutes per session. There is the 10.6 micron CO2. Again, that may get to the lamina propria quicker, but that is an ablative technique. So in my opinion, the 9.3 micron being non-ablative, getting to the collagen as quickly as it can, is probably one of the better applications and easier applications for patients. So they did some studies on some Wistar rats, and in this study, it did show that the tissue stiffness was increased by 13 times after day 1. This stiffness was maintained after 35 days and continued to become stiffer as that time pursued. It had no negative side effects. no lasting effects after day 1, other than a little bit of soreness. And this thickness was observed to continue over time. And so studies show that if collagen is not treated, it really doesn't do much. When treated with the 9.3 micron, the stiffness increases over time. Now, this time is called the neocollagenesis. That's when it's ablated initially, where it goes from the inflammatory stage to the proliferation stage to the maturation. So that takes about 21 days. So when I'm treating patients with the 9.3 micron, I'm going to schedule 2 appointments. The initial one is the first appointment, and then the second appointment is about day 24 to 28. I tend to want to get to that collagen at that time because it's the young, mature collagen. If you wait till 60 days after the initial appointment, that's going to be pretty well-established collagen, so you may have to do 2 applications again. So when I do have patients after the initial consultation, examination, they schedule 2 appointments 24 days to 28 days apart. Again, the reason for that is because I want to get to the collagen when it's young, mature collagen. I tend to have better success with those days. So regarding the results of this treatment, it can be very life-changing. We get that a lot in my office, how patients tend to sleep better. Not only that, but their spouses get back in the bedroom together, and they're able to enjoy life again. So these are some of the just testimonials that I've had from my patients in my office about how they dream more vividly. We hear that a lot because they're in a deeper sleep. They feel that they can get a better inhalation, that they have more room back there. They get a deeper breath in through their nose because of that contraction. But also that they continue to sleep well. And, you know, there's an old saying, happy wife, happy life. So I'm not saying all treatments are done for the men, but we do treat a lot of women, but again, more so are men. So these testimonials are just a great reassurance that the treatment is working. One way that I like to make sure that the treatment is working is I like my patients to download the SnoreLab app. And I make this a specific request. When I was treating them early on, I gave it as an option. And now that everyone pretty much has a smartphone, you can easily download this app and you can start recording that evening. And so I like this because I want to have a numerical value. I want my patient to see where their snore levels are at. Plus, it gives me a good understanding of how bad their snoring is. You know, I can't judge it by what their spouse is saying because a lot of times they just may be a light sleeper. So I like to kind of see the breakdown. You know, it goes through the different cycles of the sleep. It will kind of give you a better breakdown from quiet to light to loud to epic. So as we treat these patients, I want them to continue to record the SnoreLab app. I want them to see their epic go down to light or quiet so that we see less epic, and thereby that their numerical values are going down. It's just a great means for the patient to see that this treatment is working. Sometimes I've had patients who decided not to download this and they said their spouse noted that they're still snoring. Well, maybe their spouse is a light sleeper and that they're picking up on some very light or quiet snoring. So I do like this SnoreLab app. It is free. After about 3 recordings, they may ask you to purchase it. So I don't know what the fee is for purchasing the app, but I've had a lot of patients do that. And then you know, use it as needed. But I do like them to use this throughout the treatment so we can kind of follow their snoring. This is a case here that we just looked at. We've had very large snoring level here on pre-treatment of 133. You can see the epic is at 2 hours. After 4 days of post-treatment, you can see that the epic has gone down to 7 minutes and the snore score is down to 20. That's a pretty big turn for that. Not every patient responds this well, but I have had patients respond similarly to this. Most of the snores I do, that's a pretty high number, might be in the 80s, might be in the 60s. I have had several patients in the 200s. With that high of a snore score, I definitely encourage them to get a study done. If they don't desire or they refuse, obviously a consent form is signed in my office. With that high of a level snoring, OSA is definitely a probability. And if they don't get any resolve with the snoring, again, I push for the sleep study. So the Snore Lab app is just one means to really kind of pursue a numerical value to assure the patient, how is this working? Is it working in our favor? Are they having success? Because they don't know whether they're snoring or not. Keep in mind too that the Snore Lab will pick up white noise in the bedroom. So if someone has a fan on, it may pick that up. So be very consistent with how they use this Snore Lab app. Make sure they place it in the same place every single night to get consistent results. If the spouse is snoring, it will pick that up. And so keep that in mind as well. I've had several patients say, well, I'm going to sleep in a separate room tonight to get my baseline. I said, that's great. But if you do further studies or snore scores and your spouse is snoring or it's in a room with a white noise, it may pick that up. So keep that in consideration when you do this Snore Lab app. So the Bolamperti is a great classification. This was from two doctors at the Virginia Sleep Institute. And I'm not a big fan of pictures for the Bolamperti because it can be misgilded, say, by, maybe the patient was exaggerated placing their tongue out. Maybe they vaulted their palate on the after picture. But I will tell you that we have had all of our patients gone from a Bolamperti 4 to a Bolamperti 3, or even to a possible Bolamperti 2 after 2 successful treatments. So the Bolamperti is a great way to kind of check, after that first application, when you start the second. And I do find that when you do treat after the first session, the second session, that airway is more vaulted, it's more open. And so I'm able to get more surface area treatment back there, especially for those gaggers, which can be very complicated. Here's another Bolamperti display here. Again, with this, maybe the tongue posture is a little bit different. Maybe that arch is vaulted a little bit by the patient. So I'm not a big fan of it, but you do see an improvement in the Bolamperti. That's a proof in that the science is working, that this 9.3 wavelength is successful in accomplishing a vaulted palate and contraction. So there's some other things to kind of take into consideration. I get a lot of patients who come in for snoring and discussion, and I always do a good assessment of their oral cavity, looking at the attrition of the teeth, looking at skeletal discrepancies. Again, confirming nasal breathing versus oral breathing. If a patient does have a lip or tongue tie, I will definitely address that. Long-term mouth breathing, especially in our kiddos, can you use this 9.3 micron to treat children? Yes, you can. There's really no contraindications with it because it's not ablative. But I would say that if you have a child who is snoring, why are they snoring? Are they a mouth breather? Mouth breathers tend to have larger adenoids and tonsils because of that micro trauma, not to mention the bacteria associated with aspirating through the oral cavity instead of the nasal septum. So again, why are they mouth breathing? Is it because of tongue posture? Do they need to see an ENT if their adenoids and tonsils are enlarged? And so again, this ties into that what the ADA has promoted, that we need to screen these patients. This is all relevant to airway-centered dentistry because these things will influence the breathing and snoring, obviously. Most patients who have a tongue tie, I definitely will address that because I will have better success with that in sleep, better success with my snoring application. Tongue posture is huge. If there's a tethered tissue, I will address that and let the patient kind of determine which path they want to assume. I would definitely easily say that most patients, if they are have tethered tissue, changing that biology, meaning releasing that frenulum with the aided, assistance of the myology, of course, that's the only way to do it, is you have to incorporate a myologist to have success with this, and then treating the tethered tissue, their snoring is going to decrease. If they are still snoring after releasing tethered tissue, then I hit them up on the 9.3 micron and wipe that out, because now that their tongue posture is improved, nasal breathing is achieved. If any snoring is going on and it is palatal, the 9.3 is going to be way more successful than if you didn't put your attention to those items first. I know that because I've done it the other way, where I've treated just the snoring and didn't have high success. So the patient opted to go with the tethered tissue and go down that path. So I've had patients pursue each path differently. Nonetheless, we've had great results in the end. Some just choose to do the snoring treatment first, thinking that might resolve their snoring. So then if not, then again, we put them to the myologist and do a release and then follow up with healing afterwards. So this is just a representation of a release of the tongue here, posterior tongue tie with the 9.3 micron. And so you can see how it controls the hemostasis. Incredible coagulation. One thing I love about the 9.3 micron, the CO2, is the capability of coagulation. There is no bleeding with this. Now, this is probably one of my early releases. Isn't my release, but when I first released patients, I'm sure I did a very superficial release like this. This is called a frenectomy. Now I do more what's called a frenuloplasty. So I do open that up more, get into the genioglossus muscle, much like I was introduced at the Breathe Institute, and do a frenuloplasty, going after that deeper fascia. And so if you do pursue this, definitely, again, seek the proper education so you get good, study it, educate yourself, because this can get you into a mess. It's very vascular under that tongue. If you happen to hit something unexpectedly, that will bleed. Now you have an emergency on your hands. So educate yourself. But even with this superficial release, you can see how that tongue just falls back. They're going to have some success with this, and I would anticipate that the myologist has been introduced so that we're getting better results. So this is just a simple case to kind of finish up this discussion. This was a patient who came to my office from the myologist. They had a prior release on the labial, maxillary labial with a diode laser. And so it was ineffective because they didn't get to the thicker release up top there in the vestibule. When I open the maxillary buccal, my technique has changed in the last couple years. When I show you the next slide, it's more of an open release. My releases now are more closed, which means I do a very simple incision with the laser, open it up, and I go in with cotton tip applicators laterally, and then I suture the patient. Now this patient has a very tight frenulum under the tongue. They cannot get that tongue to spot, very difficult. It's very fine. You can see when they do the suction that they're very much closed. So their cave or their suction is a lot of compensation on the floor of that mouth. And so this patient is having some issues with sleep and needs a release. So we introduced the myologist. I do not do a release if they refuse to see the myologist. When I was early on in my career, I would say, well, let's just give you some exercises. I'd have them start doing that. I'd see them a few weeks later, do the release, have them follow up with those exercises. My results were hit and miss. They didn't really get really good till I came across a wonderful myologist. So myology is key. My release means nothing if I'm not doing myology. So I stress that to the utmost degree, because the only way you're going to have success with this is getting familiar with what they do and really appreciating what they do, because that's going to make your case more successful. So in this case, we decided to do the maxillary buccal and then the mandibular lingual, the tongue. So you can see what we achieved. Again, my maxillary buccal on the upper right, this was a case where I left it open. I do get to the base of the nasal, the nose. So I can definitely see that we had a good healthy release because that fascia does run deep. And again, currently I do suture that. I do a lateral incision. I don't open it that wide as much. And so it's much cleaner and heals a lot better. As you can see on the left, the tongue, right after the procedure, this is immediately after, there's no bleeding. It's sutured up. Sutures stay on the site for at least 3 days, 3 to 4 days, sometimes longer depending upon the patient's healing. We have the patient see the myologist about 3 to 4 days after, and that's when the sutures come out if they are ready. Most patients' sutures are ready to come out. Unless they're slower at healing, then we keep them in for another day or two and have those removed. But if they don't have anything scheduled with the myologist, I definitely make sure that they get in 3 or 4 days later, the day of treatment. I want them to see that myologist as soon as possible just to start their post-op therapy. This is weeks later, about 3 weeks later. You can see what we achieved with the tongue release. The tongue on spot, that distance greatly enhanced. They can lift their tongue up without compensation. With the cave or the suction on the lower right, you can still see there's some swelling. That will resolve with complete healing in about 8 to 10 weeks. And so they're doing myology for a great duration of that time. Again, myology is key. That's what's going to promote the success of this. And so these are just great examples of what you can do with the 9.3 micron because of the incredible coagulation. I don't think I would be doing this if I did this with the scalpel. You know, we're taught this in dental school and with the Z-plasty, and I definitely would not take a scalpel to either one of these two sites because of the bleeding components and how that would lead to chaos in my office. So you take bleeding out of the equation with the 9.3 micron and you have success. And so this is why I get a lot of referrals from not just within Omaha, but outside Omaha, from different states around my surrounding states, because we have a great approach to how we treat, and we have high success because of the support of our team. You cannot do this alone. You need the help of myologists. You need the help of chiropractors for those babies, lactation specialists. You cannot do this alone. You need your team. So find your team, educate yourself, and make sure that you're using a laser that is appropriate to give you the best coagulation. And I find that the 9.3 does just that. So we've had a lot of success with these patients in treating for snoring to doing releases. This is my private email, and I would say that if any of you have questions pertaining to this or anything else, you can definitely email me. I look forward to the actual meeting again coming up in August for the American Academy of Craniofacial Pain. And again, we'll be discussing more about lip and tongue ties, the myology involved. We'll have some live videos of patient testimonials, and we'll do some further patient triaging, say, for snoring and how I go about that in my office. So with that, I want to say thank you for the opportunity again to educate you tonight on what I do here in Omaha, Nebraska at my office for treating patients for snoring and tethered oral tissue. Shay?
Fantastic. Thank you so much, Dr. Bolamperti. Great information. We do have a few questions. The first one is, does the incision post-release heal at all mucosal levels after 8 to 10 weeks, or does that occur beyond that time?
I think the deeper, the deeper mucosal levels will heal beyond that 8 to 10 weeks. The initial healing starts rather quickly. I think, like I said, I used to leave the sites open, especially under the tongue. I would leave it open. And I just find suturing provides a better healing component to that, the outer mucosal layer. Deeper mucosal layers with the myology tends to heal greatly. And again, the myology is what I stress because that's what's going to make this so successful. So healing probably is not completely completed deeper for at least, I'd say 12 to 14 weeks deeper. But with myology, 8 to 10 weeks is adequate time for healing and for good results.
Perfect. We also have a comment that someone would like to thank you for your mentioning of the myologist. So thank you for that.
Oh yeah.
What is your most successful treatment option?
Oh, I have so much success with doing the tethered tissue with tongue and lip ties. Especially our older patients, and we treat them from adults to babies. It's just wonderful to be in that venue to be able to change lives. From the mothers who are complaining that the baby's not nursing, pain to nursing, the baby's fussy, body tension, all those complaints, to our adult patients up to 70, 80 years old, where sleep is horrible, chronic neck pain, hip pain, to where, we've had one woman who was 75 and she loved to bake. And after we did her tongue release and lip release, she could bake for 40, 50 minutes, where before it was 15 minutes because of the effects throughout the body. It's proven that fascia runs from mouth to toe. And so our adult older patients, I love treatment there. That's probably where my best success is, because we get the best feedback. It's life-changing. Sleep is always enhanced. They wish they would have done this 30, 40 years ago. And that they're resting better, so they're living better. Back pain, again, gone. They don't have to see their chiropractor as much. So we love doing everything, but I love especially doing the frenectomies for frenuloplasty from babies to adults.
Okay, and that answers kind of another question of what age will you start to treat children with the 9.3?
Yeah, 9.3 is phenomenal for babies. We get a lot of the pediatric world is difficult because a lot of them aren't educated as dentists as well. But the pediatrics can be great if they're on your side. If they're not, it can be a huge obstacle. And some pediatricians try to relieve this tethered tissue with scissors. The problem with scissors is they don't get to the depth of the fascia on babies. And so they snip them when they're born, and it creates scar tissue. And so that makes it tighter. And again, there were no stretches introduced. So, the 9.3 micron is phenomenal for babies because you can get to the depth of that fascia. You don't have to do a frenuloplasty. You just have to get to the depth of that frenulum and release that fascia. So, if you take bleeding out of the equation for babies, which you'll have no bleeding, you can have high success with it. And you can have the mother nurse right away and feel the difference. And then you introduce maybe a chiropractor, do some palatal work, or do some body tension, or a lactation specialist to help that mother assist with proper nursing. And those mothers will become your walking billboards because they have a different baby. The body tension's gone. They're more relaxed. They sleep better. They feed better. And you see a change in their physical appearance. So, and again, I think the greatest gift is you start treating babies and you say, I want to see Johnny back in a week. Okay, we're going to see Johnny back 3 weeks after that, and then a month, and then I want to see him in a year, and then I want to see him at 2 years, and then at 3 years. So no longer am I seeing children just because they have teeth. I'm seeing them as infants, watching their palatal growth that can manipulate, the airway. And so it's a wonderful thing to introduce into your practice.
And is the uveilectomy ever the answer?
I would say, maybe for some, I haven't found too many patients where that was the answer. And I think it takes a wonderful, skilled ENT who can know that difference. I know that I've heard of a few cases where it was the answer, but for majority of the patients, it didn't resolve their snoring. Again, if you just start looking at your patients within your office, obviously you can see they don't have a uvula. And so a very painful procedure, that is common. That's a common thread. It's a common complaint that it's very painful. and they wish they never would have done it because they didn't have any success. But I've heard of a couple, but I just haven't seen that many.
Okay. Let's see. Is it okay to perform a frenectomy at birth?
Yes. I always like to say sooner than later. So we've treated infants when they were discharged from the hospital. So they're there for a day and a half, 2 days. They've notified me, and the mother suspects, you know, if I have a patient and their due dates at a certain time, I always educate mom. If you have problems nursing, let me know. Let me know. We'll have you stop here after the office. I've met patients at my office on a Saturday, on a Sunday, because if I can introduce a better biology, a better environment for success, then we're going to have better results. If the mother tends to wait, then the infant picks up on, you know, that bad learned behavior, as I call it. So they're compensating, they're changing the way that they're nursing. So if I can manipulate the frenulum to give them a better latch sooner than later, we're going to have a higher success rate. And less need to introduce the chiropractor, less need to introduce the lactation specialist, because it's innate to suck, you know, to get what we need from the breast.
Okay, perfect. And why the reluctance to remove the uvula completely with the UPPP?
I'm not an ENT. I just know from the patients, you know, that I have seen at my office and patients I've talked to outside my office, people in general, that I'm reluctant because I don't think the success rate is there. And again, it's extremely painful. I'm not a big fan of taking the uvula out because it's there for a reason, you know. And so majority of patients that I've seen where they've had it removed, it didn't do them any good. And so I'm just basing off what I see within my practice and from what I hear from other people. But I'm guessing that some ENTs have success with that. But from the ones I've seen, they weren't very successful.
Thank you.
Well,
One other comment just to throw out there is that the Snore lab is a great tool to help singles. Someone also commented. So if you don't have someone that's
yes.
sleeping with you, it's a great tool. From my research, my understanding is that the UPPP has a relatively high long-term failure rate. Do you agree?
Yes. Yes.
Okay.
Like I said, I think initially, boy, it does work. It seems to cut down on the snoring, which if that's why they're getting it done, if that's their treatment of choice because of snoring, it does decrease the snoring, but it does come back. So long term, it does have a poor long-term prognosis. And again, this is based on patients that I've treated with snoring that have had the UPPP, and they've all said, hey, it was great at first, but it was painful, but then I wasn't snoring, but now I'm snoring again. So I would opt to treat snoring with something that's not as invasive as taking out your uvula. If they have a means to be treated even with the erbium or the CO2 with snoring, I would definitely encourage that first before you take someone's uvula out.
And I think that really about is all of them. I want to thank you again. We look forward to having you in San Antonio. You can, as Dr. Bolamperti mentioned, you can hear more from him there.
Yeah, thank you very much. I appreciate the opportunity. I look forward to seeing you all in San Antonio in August. Thank you.
Thank you. Have a good night.
You too.